Hi guys. Today we're going to discuss a new topic that's recently come out as being one of the requirements of participation to accept CMS like Medicare and Medicaid funding for nursing home care. So we're going to be looking at trauma-informed care. And some of you have been here long enough that you remember when this got rolled out in 2019. We did quite a bit of in-servicing then, but there are some updates to this. And so we want to just take a deeper look at it and make sure that we're all familiar with what this means, and that we have a good understanding of how it impacts us working in the nursing home. And the good news is, really, is that providing culturally competent care is something that we've already been doing. It's something that our admissions team looks into, and we all take part in making sure that the residents who live here feel safe and feel protected. We want to foster an environment that is ultimately healing, and we want to create a safe place where people can be themselves and express themselves. And we're already practicing with an emphasis on safety and person-centered and person-directed healthcare. So, like I said, we've already been doing this. There's just some information that we need to pass along to make sure that your understanding of this topic is thorough. And so, the reg is new-ish since 2015. It's really just being enforced now. And the regulations state that a facility, so Moral Home, must ensure that residents who are trauma survivors receive culturally competent, trauma-informed care in accordance with the professional standards of practice and accounting for residents' experiences and preferences in order to eliminate or mitigate triggers that may cause re-traumatization of the resident. So I stole this story from someone else, and I'm going to read it to you, and then we'll kind of unpack it as we go. So let's meet Abigail. Abigail is 94 years old. Her husband passed away 7 years ago, and since then she's been living in a retirement community. Her 6 children take turns coming over to check on her every day and to make sure she has clean clothes, easy meals, and that she takes her medications. Abigail's dementia has progressed to the point that she stopped being able to be left at home for most of the day. She needs help getting dressed, going to the bathroom, and getting around her apartment. She needs a wheelchair for her mobility, to go long distances, and a walker to go room from room. After falling a couple times at home, her adult children decided to move her to a nursing home so she can receive more supervision and care. Abigail is a very nice lady for the staff to take care of. Doesn't she look like a very nice lady? She does get confused sometimes and tries to get out of bed on her own almost every day, but she's very accepting of redirection. She expresses a lot of gratitude when the staff assist with her getting dressed and getting to the dining room for meals and going to the bathroom. She readily accepts care and seems to enjoy the company of other people, residents and other staff. One day, one of the nursing assistants comes in to help Abigail with her bath. So Abigail's pretty new at this point, and she knocks on Abigail's door, and she comes in and says, "Good morning, I'm here to take you for your shower." Abigail, in a most uncharacteristic Abigail way, starts screaming at the CNA, "I will not go with you to the shower. You get out of here." When the staff member tries to approach Abigail to calm her down, Abigail begins flailing her arms and trying to hit and bite the nursing assistant. Abigail's still screaming. Another nursing assistant hears the yelling from outside the room and runs in, and she asks Abigail what's wrong. Abigail's still screaming, flailing her arms, and yells that she will not go to the shower. The second nursing assistant says, "Okay, Abigail, you don't have to go to the shower today. I'll get some washcloths, and we'll just get you washed up and dressed in here." Abigail starts calming down and allows the second nursing assistant to do her other cares. The nursing assistant reports the behavior to the nurse. The nurse says, "Well, maybe she has a UTI. We'll check it out." Over the next few weeks, every time Abigail is scheduled for a shower, the same behavior happens. She starts yelling and flailing her arms at the nursing assistant staff members. She attempts to kick them and bite them. The staff don't understand what's happening. Abigail is normally very sweet, very agreeable. They can't see why she's being so combative and hostile and non-compliant. The nurse assesses her. Abigail's vitals are normal. Her labs are normal. She does not have a UTI, and there doesn't seem to be anything medically wrong with her. The nurse reports these behaviors to the doctor and asks the physician to consider anti-anxiety medication prior to bathing. One day, a nursing assistant comes in to help Abigail with her bath. Abigail's been living in the home for 3 weeks and still not had a bath. Her hair is greasy, her skin's oily, and she's starting to smell. The nursing assistant has worked with Abigail before, so she knows that if she tells Abigail it's her day to go to the shower room for a bath, Abigail will become hostile and combative. The nursing assistant asks Abigail, "Hello, Abigail. I want to help you get cleaned up today. Your hair hasn't been washed in a long time, and I want to help you look nice for when your family comes to visit. Can you go down to the beauty shop and get your hair washed with me? I'll wash it in the sink." Abigail agrees to that, and the nursing assistant is able to get Abigail's hair washed with no problems. So Abigail's son comes in to visit a few hours later. The nursing assistant comes in the room to drop off a water pitcher, and the son says to the nursing assistant, "My mom looks so nice today. Did you help her with her hair?" And the nursing assistant tells him yes, and then asks the son, "How did she take showers or baths before she came here? No one can seem to get her in the shower room. She's so agreeable most of the time, but when someone mentions the shower, she changes and starts hitting and biting us, and she just isn't like that most of the time." Abigail's son excuses himself from the room and asks the nursing assistant to come into the hallway. Once outside of earshot, he said, "I should have told you all of this before, but I didn't think it would come up because my mother hasn't talked about it in years. She and my dad were both Holocaust survivors." The nursing assistant thanks him for the information and says she'll give this information to social services, who might be in to ask him some questions later. After learning about Abigail's history of being a trauma survivor, the staff were able to change the way they approached Abigail on her bath days. They stopped using the words shower and shower room entirely and changed their terminology to words that didn't trigger Abigail's anxiety or stress. When Abigail was scheduled for a shower or bath, they would be able to use words and phrases like, "Let's wash your hair today," and "I'd like to help you with a nice bubble bath." Everyone was very diligent about making sure they did not re-traumatize Abigail. After the son shared parts of her story with them, they realized that Abigail was not exhibiting non-compliant, intentionally aggressive, or mean behaviors. She was afraid, and every time a staff member came in to take her to the shower room, she thought she was going to die, and she was re-traumatized every single time they asked, and she had to relive those experiences. That story is from a few years ago, but I think that it demonstrates a good point. It's that, we didn't, maybe if we would have known, or if that facility would have known about Abigail's trauma, we wouldn't necessarily have been asking to run a UA or run all these labs or start anxiety medications that she probably didn't need. So that's kind of just one of the takeaways from that. We want to define trauma. Individual trauma results from an event, a series of events, or a set of circumstances that's experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's function and mental, physical, social, emotional, or spiritual well-being. One of the most surprising things about learning about trauma and trauma-informed care is just the prevalence of it. Most people have it. Most people have trauma. Up to 90% of people have something or report something that's been a traumatic experience for them. The low number is 55%. So out of the 60 residents who live at the Morrow home at any given time, if only the low number is true and only 55% of our residents have experienced something traumatic, that means 33 residents require trauma-informed care or have trauma that still affects them, to this day. So lots of people are going through this, and it's kind of a given. And I know that we hear it and we see it a lot of times. I know it's very prevalent on social media, that we need to be mindful and aware of other people's life experiences and what they may be going through. Um, and that's true for our residents, and that's true for other staff, and that's true for a lot of people. Lots of causes of trauma. I just named a few, and then the medical community has been studying trauma really intensely for probably 20 or 30 years, but we're just now in the last 5 to 10 years learning about what all goes into that study. And a lot of the trauma testing that was done, or a lot of the trauma study and research that was done, was on post-traumatic stress disorder. The VA did a lot of research on that. And then the CDC came in and they also did a lot of research on that. And so what they also found was that trauma can start at any age, but there are some adverse childhood events that are more likely to lead to trauma in people as they age and grow up. If they were subjected to physical, emotional, or sexual abuse before the age of 17, physical or emotional neglect, if they lived in a household where a parent experienced struggled with a mental illness, or was in prison, or watched one or the other parent be abused, substance abuse, and divorce. So any combination of these things can lead to the need for trauma-informed care and can lead to a traumatic experience. And we're just kind of learning about all of those things now and how it affects people later. But if you think about it, in our facility, in our industry, some of our residents who may have experienced traumatic events, traumatic childhoods, traumatic things that happened in the wars that they were in, anything really could have happened. They may not be able to talk to us about it. They may not be able to tell us about it. We might have to rely on their family members or their kids or their nieces and nephews to tell us about it. But those traumas can have physical and mental ramifications for the rest of their lives, even after the memory of the trauma fades. And so if you think about residents with cognitive loss and dementia, they don't necessarily know why they're feeling how they're feeling, why they're scared or why they're panicking. They just know something's not right. And aging is tough in and of itself. Getting older causes a lot of stress. There's a lot of loss. There's a lot of potential traumas. Losing loved ones, watching people you love get old and pass away, losing your home, moving into a nursing home, losing your defined role as a mother or a father or a grandfather or a grandmother, and definitely losing your independence. I mean, all of those things in and of themselves could be traumatizing to our residents. And then I think it's also important that we realize not everyone's going to experience trauma in the same way. We all have different physical and mental fortitudes and capacities, and we're all supposed to be different. That's just kind of how it is. So a police officer who gets called to the scene of a car accident to help cut someone out of a car who's severely injured might be very proud of his ability to help that person, whereas a bystander who witnesses the accident and sees the injured person might have a trauma response. Having a trauma response is up to the individual who experiences the event, and nobody gets to decide for someone else whether or not an event was traumatic. And especially true for all of us who work in healthcare with things that we're going to experience and things that we're going to see. Some nurses have been nurses for 25 or 30 years, and they'll run to a code, and they'll run to a trauma, and they'll run to an accident. They'll run to take care of someone with a terrible wound. And maybe someone who's just starting out in healthcare, who's never experienced those things before, sees one of those things happen for the first time and is devastated. So all events can potentially be traumatic or not. How we experience those events determines whether or not we had a trauma response, and then the effects of those adverse events. If we're having a trauma response might cause our inability to effectively cope with some normal stresses, and it can fundamentally change who you are and how you interact with the world as a human being. So it's important. Through the admission process, the admission team is going to take steps to try to ensure that trauma is identified. So we want to ask the resident, talk to their family, be receptive when they discuss past experiences, especially pay attention to mental illnesses listed, a history of post-traumatic stress disorder that are listed, and then we need to care plan those things and make sure that those things are assessed and that we know that they need to be addressed and dealt with in a certain way, and develop approaches to making sure we do not re-traumatize somebody. Now consider you probably already know some things about people's reactions to traumatic experience. So we know that people may, especially with dementia, may have behaviors or reactions that we don't necessarily understand. And like I said, most of the work and research that's been done with trauma has been for veterans. So PTSD, that information is still quite relevant to our population. You hear about veterans suffering from PTSD and they avoid Independence Day fireworks or have nightmares or sleep disturbances. So those symptoms are the same in a lot of different types of trauma, and avoiding things, places, people can be an indicator of trauma. It isn't always, and it doesn't always mean anything, but there's stuff to watch for there. Getting startled easily, becoming easily irritable, quickly becoming aggressive, difficulty concentrating, their reactive behaviors, and possibly symptoms of experiencing some sort of traumatic event. Trauma can affect your cognition and mood, lead to overly negative thoughts, very negative feelings and emotions about yourself, about certain other people. If you think about Abigail and her extreme reaction to the shower room, it doesn't seem like taking a shower should be quite so stressful, but just the word was frightening and upsetting to her. So we need to start being able to ask the question, like, what happened to you? So that we can try to understand what people's lives were like and how we can help those people. All right. So, discussing what we just learned and what we know, let's go through some quizzes. So please complete your quizzes and turn them in. This in-service is required for everybody. So everyone at the Morrow Home will have to take the quiz, whether you work in nursing or housekeeping or laundry or culinary or reception. We all have to take it because we're all possibly going to have some experiences with our residents, and we all need to know about trauma. So when a person experiences trauma, the effects of that trauma are always immediate, and we know that answer is false. Adverse effects of trauma can occur immediately or after a delay, and the effects might include an inability to cope with normal stresses, inability to trust, and cognitive difficulties. If an older person has experienced trauma, which of the following is not true? A, providing support in a safe environment can help an older person heal. Our brains can really only heal and change when we are young. Older persons may feel uncomfortable talking about a past trauma because the fear of the stigma. Older persons may have experienced childhood trauma and adverse events throughout their lives, including traumas involved with the aging process. Which one's not true? And that is B. One interesting thing about older adults, however, is that they have lifetimes of experiences and wisdom and have developed resilience. The resilience of older adults is something most younger people just don't have yet, and this actually helps residents and older people who experience trauma with healing. Question, only a small portion of the population has actually lived through a traumatic experience, and that we know is false, because between 55 to 90% of people have experienced some form of trauma. So the majority of people that we're talking to and interacting with on a day-to-day basis has had an experience or event that continues to affect their normal everyday functioning. Trauma can be caused by which of these things? Natural disasters, crashes, being the victim of violence, emotional abuse or neglect, or all of the above. And we know that answer is all of the above. Experiencing or witnessing emotional, physical or sexual abuse, domestic violence, natural disasters, cars, plane crashes. It's all from slide 9. We should only be concerned about providing a safe and healing environment for residents and older adults who have experienced trauma. Obviously, no. We need to make sure that we create a safe experience and environment for everybody, because the range of people who have experienced trauma is very high, 55 to 90%. And there's a range because we're guessing that we know at least 55% of people have experienced trauma, but we do not know what the other people have experienced. So not everyone who has trauma is going to report it, and we need to make sure that we keep everybody safe regardless. Learning about the signs and symptoms of trauma is important because, why? We can help ensure that the older persons in our care feel safe. It can help prevent misdiagnosis and unnecessary use of psychotropic medications. It can prevent us from unknowingly re-traumatizing someone. It can help us make sure of some puzzling behaviors. I didn't write that quite right. Or all of the above. And the answer is all of the above. So if you have any questions, please let me know. I am happy to help. I am happy to answer questions, and I'm happy to point you in the direction of resources if you would like to learn more about trauma-informed care. So thank you very much for tuning in to this education. I appreciate it, and we will get it uploaded. Thanks so much.